No more will log in. Welcome everyone to Geriatric Medicine Grand Rounds. Happy Friday. It's already the latter half of May. And so what that means is our Geriatric Medicine Fellows will be presenting the next several Geriatric Medicine Grand Rounds. They always present a topic of their choosing at the end of the year. And Dr. Leenah Chughtai, who is one of our geriatric medicine fellows who you've all gotten to know over the year, is presenting today on oral health and geriatrics. She's the first fellow to go this year. She also is the first fellow to graduate. She finishes a little bit early, around like the 23rd of June, and so she gets to go first. And I'm really excited to hear your talk. All of the geriatric medicine fellows over the last few years have been able to spend some time learning about oral health from Dr. Jeffrey, and I'm really appreciative of that. It's so important and something that's undertaught in geriatrics training across the country, and something we all need to know more about. I welcome those from the School of Dentistry that are here this morning, and all of you, and I'm going to let you take it away, Dr. Chughtai.
Well, good morning, everyone. So today I'll be talking about oral health and geriatrics. Certainly not a comprehensive presentation, but some pearls and some things that I think are important for healthcare professionals to be aware of. So first of all, I'd like to give a special thanks to Dr. Jeffrey in assisting me with in the creation of this talk. So thank you so much also for being present. All right, so some objectives for today. So as I already mentioned, I'd like to address the vital role that healthcare providers can play in promoting the oral health needs of older adults. I'd like to go through completing an accurate oral assessment, identify some common geriatric oral conditions, address the link between oral and systemic health, and address the link between common medications and oral health. All right, so why oral health matters. We know that oral and systemic health are tightly connected, but even more so in the geriatric population. So this slide is a small summary of things that I will be elaborating on further in the presentation. So poor oral hygiene is associated with an increased pneumonia risk. There are many medications that disrupt saliva secretion, thus increasing the risk of dental caries. Diabetic glucose control and periodontal disease are directly related, with poor diabetic control worsening periodontal disease and vice versa. Poor oral health can cause weight loss and even failure to thrive. And so healthcare professionals can improve the overall health of their patients by helping to address oral issues. Okay, so the oral health needs of older adults. So as healthcare and dental care have advanced, patients over the age of 65 have increasingly complicated dental needs because they retain more of their teeth, yet they still have high levels of disease. So 1 in 5 older adults have tooth decay. Quite a high percentage of older adults have gum disease. Nearly 1 in 5 adults 65 or older have actually lost all their teeth. And complete tooth loss is twice as prevalent among adults at 75 and older compared with adults 65 to 74. And then cancers of the mouth, so both oral and pharyngeal, are primarily diagnosed in older adults, with the median age diagnosis being around 62. All right, so which geriatric populations are at risk? Of course, those living in poverty. So about 8.8% of older adults in the US live below the poverty line. That's about 4.2 million, with another 5% being considered near poor. Those older adults with at least one chronic disease, and of course, many have multiple chronic illnesses. The comorbidities that were frequently diagnosed when patients with the most common oral pathologies were arthritis, heart disease, cancer, diabetes, and hypertension. Those patients with disabilities and activity limitations. According to the US Census Bureau's American Community Survey, some type of disability, meaning difficulty in hearing, vision, cognition, ambulation, self-care, or independent living, was reported by about 35% of people over the age of 65. And then rural. So in general, rural areas tend to have a larger percentage of older adults. The percentage of Americans that are 65 and older that live in non-core rural areas, meaning areas with populations less than 10,000, is 17%, compared to the US as a whole, with 15% of the population over the age of 65. And so rurally located individuals have less access to dental and other forms of healthcare. All right, so who else has limited access to care? Because only 43% of the geriatric population actually visit the dentist. So there is a big majority of those that lack dental insurance. As previously discussed, those living in poverty, living with some sort of disability. Also those with limited mobility and limited access to transportation. Those individuals that reside in facilities. And then interestingly, the prevalence of specialized geriatric dentists also, of course, plays a role. So until recently, there was no clear career path in the US for individuals who wanted to specialize in geriatric dentistry. Brazil was actually the first country to recognize a specialty in geriatric dentistry in 2001. All right. So we'll go over an oral health assessment. So first of all, of course, we're going to assess for symptoms that are suggestive of oral problems. So taking a close look at the face, the lips, especially the vermilion border of the lips, the teeth and the gums, mucosal surfaces and saliva, the soft and the hard palate, and then the lateral borders of the tongue and the undersurface of the tongue, and the posterior pharynx. And then on palpation, palpating the neck, the TMJ, and if you're thinking of something specific, also palpating the floor of the mouth. Okay, so first coming to the face and the lips. So examining the face and the lips, the face with the lips at rest, looking for any deformities as well as any skin or perioral lesions. So the picture at the top there, the arrow is pointing to a small lesion that I think if you just briefly glanced over the picture, you might not notice if that arrow wasn't there. So squamous cell carcinoma of the lip is common, and it may present as a dry, scaly, or ulcerated non-healing lesion, especially at the vermilion border. Also, creasing of the facial skin at the lip corners is often due to tooth loss, due to poorly fitting dentures that will also predispose patients to angular cheilitis. Gums and teeth. So healthy gums are pink, they're moist, they're smooth, they don't bleed when they're touched. So the ideal oral assessment would be done with removal of the dentures. You'd be looking at oral hygiene status, and then assessing for caries and root caries, which this bottom picture is an example of. And then gingivitis and periodontal disease. This top picture is a pretty clear example of gingivitis. Other things to be looking at when looking at gums and teeth. So cracked teeth, broken teeth, missing or worn teeth, and very obvious signs of tooth decay. Okay, age-related changes. So with age, teeth can become darker, can become more yellow in appearance, which the top right-hand corner is a picture, is an example of. Enamel will thin as we age, and so that allows the naturally darker dentin layer to show through much more prominently. Teeth also begin to wear down with age, known as attrition, and so they may stain when exposed to nicotine and coffee, which the bottom two pictures are examples of. Gingival recession may also occur, as seen in the top left picture. That will result in exposure of the root surfaces of the teeth. All right, so I will briefly talk about implants, dentures, and bridges, just to highlight how they are important for us to consider in our patients. So implants are surgically placed into the jaw, and they're usually crowned. Some patients may ask their healthcare professionals if they should have dental implants placed. And so for patients with a healthy mouth, with a history of good oral hygiene, with few comorbidities, that's usually a straightforward procedure. But some considerations to keep in mind: implants are contraindicated in patients who have received IV bisphosphonates. And then poorly controlled diabetes or serious bleeding disorders are also of concern. All right, removable dentures. So dentures can be complete, they can be partial, as in the depiction in the bottom left-hand corner. So when we are taking a look in the mouth and we ideally have the patient remove their dentures, we can assess for fit and for comfort. You can also note if there are any broken areas, any missing prosthetic teeth. And then bridges, which are shown in the bottom right-hand corner. So fixed bridges, those will replace one or more teeth, and they're connected to the adjacent healthy teeth using a crown, and those cannot be removed. They're more difficult to clean, and the area under those are more prone to caries and to gum disease. All right, coming to the mucosa. So as shown in this picture, healthy mucosa should appear pink, wet, glistening. We want to pay particular attention to the mucosa under dentures. Aging will result in thinning of oral mucosa as well as decreased elasticity of the mucosa. And then dry mucosa will interfere with things like denture retention, and a lack of saliva will also increase the risk of caries. And I will talk further in detail about saliva later. All right, the tongue. So we want to inspect the lateral margins of the tongue as well as the undersurface of the tongue, where pathologies can often occur. Some age-related changes we can see: you can have fissuring or mucosal thinning, as well as sublingual varicosities, which this picture is an example of. Now, although the number of taste buds does actually decrease with age, diminished taste sensitivity is much more often due to smoking, medications, and dry mouth rather than that decrease in the number of taste buds. Okay, oral pain. So we really need to be alert to the fact that oral pain is often one of the first signs of some sort of a problem. Oral pain is very, very common. It can often be vague, difficult to localize. For example, a person may feel pain in their mouth from sinus infection, or the pain coming from a cavity might actually be felt in the ear. This is very important to consider in those with disabilities and in those that are nonverbal, because we want to watch out for behavioral signs of pain, like agitation, like delirium, refusal to eat, pulling at the face, or pulling at an area of the pain. All right, so moving on to some common oral problems in older adults. So I'll start with denture problems. So ulcerated mucosa from denture irritation, that can occur with ill-fitting dentures, so very important to assess for comfort and fit. With poor oral hygiene, if patients have poor oral hygiene and dentures, that can be quite a problem. And then dentures that are left in too long, which I will discuss a little bit further in the next slide as well. So really, dentures should be removed at night to let the oral tissue rest. Saliva decreases at night and bacterial counts increase at night. So continuous denture wear can result in problems. Angular cheilitis, which again, this picture is an example of, is common when dentures have insufficient vertical height. Okay, denture stomatitis. So this is referring to erythema of the palate with cobblestoning, if you can see in this picture right in the middle here. So the openings of the small salivary glands, those get inflamed and then appear raised in cobblestoning. This can be asymptomatic and the etiology is complex, it's multifactorial, but we do know that Candida plays a role. And the most prominent risk factor, as I discussed in the previous slide, is continuous denture wearing. Other risk factors are also xerostomia, diabetes or immunosuppression, and various nutritional deficiencies. All right, coming to caries. So saliva contains over 2,000 proteins and peptides, many of them having an antimicrobial function. And so when salivary flow is low, patients have less of an immune response in the oral cavity. And also there's less of the natural cleaning function of saliva. So that means there's more food particles in the mouth. And so the dietary carbohydrates in those food particles are metabolized by oral bacteria into acids that will then destroy the tooth structure, leading to caries. So root caries are common in older adults. This picture from a previous slide where you can see gingival recession and then exposure of these root surfaces. Gingival recession will expose those susceptible root surfaces, excuse me. And so root caries in those areas will progress more rapidly. Mild disease can often be asymptomatic, but of course, depending on severity, you can have like pain with just eating, with temperature changes, and all the way to cellulitis or an abscess. Some risk factors for caries. Xerostomia, inadequate fluoride exposure. So tooth decay is a common sign of fluoride deficiency. Low fluoride exposure can create an environment for the bacteria that are found in plaque or biofilms to thrive by allowing them to produce acids that will wear away at the tooth enamel. Low socioeconomic status, dementia, existing restorations or appliances, recurring caries are common at the site of existing restorations. Frequent consumption of sugary foods, and then medications that decrease salivary flow or medication preparations that contain sugar. All right, gingivitis. So gingivitis is characterized by inflammation of the gingiva without destruction of the periodontal ligament or bone. And so that is what distinguishes gingivitis from periodontitis. Symptoms can include mild gum swelling to tenderness, erythema, bleeding gums. It's due to plaque buildup as a result of poor oral hygiene. Can also be due to changes in hormone levels that can modify the gingival response to plaque, as well as acute gum inflammation can also be the result of an oral foreign body, for example, a piece of popcorn kernel getting stuck between the teeth. Okay, so periodontitis. So this is where chronic plaque exposure will cause inflammation, leading to destruction of the periodontal ligament and loss of the supporting bone, resulting in tooth loosening and eventually loss of the teeth. Prevention and treatment, so having good oral hygiene, having regular dental visits, also cessation of irritants like tobacco and cannabis. Can also prescribe topical solutions like chlorhexidine, and the caution with chlorhexidine that it may stain teeth yellow to brown, can alter taste temporarily. The taste may even be such that it's completely unpalatable for the patient. All right, leukoplakia and erythroplakia. So oral leukoplakia, I think we recognize as sort of the best known pre-malignant oral lesion. So that's what's known as the white patch or plaque. It's analogous red lesion called erythroplakia. These can often be asymptomatic and really only noticed when someone looks in the mouth. Progression may lead to elevated plaques that ulcerate. And so 90% of cases where biopsies are done, this is found to be epithelial dysplasia, carcinoma in situ, or invasive squamous cell carcinoma. So really with these lesions that are persisting and you don't have another explanation for it, these should absolutely be biopsied. Okay, oral cancer. So there are 49,000 cases diagnosed annually. So again, back to just the previous slide, if a red or white patch in the mouth appears, is not resolving, you really want to suspect, you want to have a high suspicion for malignancy and pursue biopsy. This can also present, as ulcers that bleed easily or ulcers that don't heal. And of course, they can present as a mass. Alcohol and tobacco are historically responsible for the majority of cases of oral cancers. And those patients who smoke pipes or cigars rather than cigarettes are at greater risk. HPV accounts for the rising incidence of oral cancers, particularly of the posterior pharynx, the tonsils, and the base of the tongue. And that's more common in individuals sort of the age of 40 to 64. And then sunlight, as we discussed with lip cancer and betel nuts. Okay, so moving on to oral systemic linkages. So first off, nutrition concerns. With tooth loss, with dentures, and with decreased saliva, patients will often alter their diet. So that can result in altered eating sensations, so not just taste, but texture as well. And then that lowered chewing efficiency if there has been tooth loss, if dentures are ill-fitting. Patients will be consuming less raw vegetables, less salads, less fresh fruit, and getting lower intake of essential nutrients, lower intake of things like vitamin C and beta carotene. Compensatory habits like sucking on mints or consuming sweetened beverages for dry mouth may result in sort of the consumption of empty calories and, of course, an increased risk of caries. Okay, diabetes. So this graphic here, so we'll start with the orange circle. This is meant to depict the vicious cycle that can occur with diabetes. So poor glycemic control is associated with a threefold increased risk of periodontal disease. And so periodontal disease actually worsens glycemic control. And patients who have periodontal disease are just twice as likely to develop diabetes. And so this becomes a vicious cycle that can, of course, be broken with better control of diabetes and regular dental care. So uncontrolled diabetes is also a medical condition that impacts dental treatment. Okay, osteoporosis and osteonecrosis. Patients with osteoporosis may experience oral changes like increased tooth loss. And then additional denture adjustments, may be required as the jaw shape changes. Osteonecrosis. So IV bisphosphonates are associated with osteonecrosis. The prevalence is rare. This can occur at the site of a tooth extraction or spontaneously. The American Dental Association does recommend regular dental care for patients on bisphosphonates. Some symptoms of osteonecrosis can range from jaw pain, swelling, infection, loose teeth, to drainage and exposed bone. Vascular disease. So periodontal disease is associated with coronary artery disease and with cerebrovascular disease, though the extent of the impact is unclear. Studies do support an association between periodontal disease and atherosclerotic disease, but not a causative relationship. So causation is unclear. We do know that inflammatory cytokines that are implicated in atherogenesis are also produced in patients with periodontal disease. And the treatment of periodontal disease has not been shown to date to reduce cardiovascular risk. And then coming to one of the sequelae of vascular disease, strokes, strokes can result in multiple oral problems. So oral sensory and motor deficits, poor tongue function and lip seal, dysphagia, reduced oral clearance of foods and increased food packing or pocketing, reduced dexterity, negatively impacting oral hygiene performance, and increased caries and periodontal disease risk. Rheumatoid arthritis. So there is a relationship between oral health and rheumatoid arthritis. Periodontal disease is more common in patients with rheumatoid arthritis, and there is some evidence to suggest that the treatment of periodontal disease may reduce the severity of rheumatoid arthritis in the short term. Rheumatoid arthritis can result in multiple oral problems like the diminished ability to chew and eat if the rheumatoid arthritis involves the TMJ, diminished salivary output as with Sjogren's syndrome, leading to xerostomia and the increased risk of caries, reduced dexterity of the hand, the fingers, negatively affecting oral hygiene performance, and then of course overall that increased risk of caries and periodontal disease. Okay, dementia. So patients with dementia have an increased risk for caries, for periodontal disease, as well as for oral infections. Some contributing factors will be depend on the severity of the self-care deficits, the dependence on caregivers, also the additional factors of comorbidities or the chronic disease burden, any dietary changes that will occur with as the dementia advances, as well as with dysphagia. And of course, the lack of understanding leading to a resistance to care. So dementia is very important with oral hygiene visits. It's important to plan for dementia in terms of oral treatments when patients are in the earlier stages of dementia. Okay, gastroesophageal reflux disease, very, very common. Gastric acid will oversaturate the buffering systems of the saliva. Going back to oral assessments, we can look or examine the inside, the lingual side of the gingival margin to look for erosions or caries. All right, so let's talk about some of the oral effects that medications have. Okay, so to talk about that, I'll briefly mention the mechanism of saliva secretion. So in this picture here, there are a couple of red boxes and some highlighted areas. So the main receptors that stimulate salivary gland acini are adrenergic, both alpha and beta, and cholinergic. And intercellular signaling through calcium channels is also important for the stimulus to reach a high enough level to elicit secretion of fluid and proteins. And so you can imagine that medications that are very commonly used, like alpha blockers, beta blockers, the large list of medications that have anticholinergic effects, then of course calcium channel blockers will have quite an impact on saliva secretion. You can sort of simplify this by saying that, if a person has 4 or more medications, there will be a clinical effect on saliva secretion, resulting in lower secretory rate of saliva and therefore a higher risk for caries and plaque accumulation, and the patient also being at a higher risk for oral candida infections. So some common medication effects, certainly not an exhaustive list. Gingival overgrowth or hyperplasia can be seen with less common medications like phenytoin and methotrexate, but can also be seen with calcium channel blockers. Stomatitis and mucositis as seen with chemotherapy and radiation therapy. Candidiasis as we see with steroids. Xerostomia, which you can see with so many different medications, but specifically antihypertensives, anticholinergics, antihistamines, and diuretics. Dental erosions that you can see with progesterone. And then caries. So not only just occurring with xerostomia, but also occurring with sugar-containing medication preparations. So something to keep in mind with patients who are already at higher risk for caries. All right, so let's talk about xerostomia. So this is a sensation of dry mouth because of decreased salivary flow, common in older adults. Saliva acts as a lubricant for the oral cavity. It promotes remineralization of teeth to prevent decay, and it protects against fungal and bacterial infections. Also, again, a very important protective factor against caries. So xerostomia is defined as less than 0.1 milliliter per minute of saliva secretion at the resting, in a resting situation. So some causes, medications, as we already discussed, rheumatoid arthritis, Sjogren's syndrome, and also radiation therapy. You can actually, I don't know if anyone has seen this with their patients, but you can actually prescribe increased strength toothpaste for xerostomia to help with that increased risk of caries. Some helpful questions to ask in patients when you want to assess for xerostomia. Does your mouth feel dry? Does it feel dry when eating? Do you have difficulty swallowing foods? And do you sip liquids to aid in swallowing? Through residency and fellowship, I've seen quite a few times when I will ask people if their mouth feels dry, if they have a hard time swallowing. They might answer no, but they will answer yes to the fact that they use sips of liquids to help in swallowing. So on exam, you will note dry mucosa, friable mucosa, and there's no pooling of saliva at the floor of the mouth as you normally would get. Okay, so managing xerostomia. Discontinuing and citing medications when possible. Also cessation of irritants like alcohol, caffeine, smoking. Cessation of sugar-containing drinks, candies. And then to prevent caries and periodontal disease, of course, recommending meticulous oral hygiene, regular dental visits, and as I mentioned before, increased strength topical fluorides. Taste alteration. This is associated with so many medications and can have such a major impact on the quality of life. As you can imagine, there is quite a link between food and enjoyment, food and joy. And so if the taste of food is taken away or is altered in a negative way, enjoyment of food is greatly impacted. And so this can lead to weight loss. It can lead to a negative change in mood and is often an overlooked side effect of medications. Okay, some conditions affecting dental treatment. Again, not an exhaustive list, but radiation treatment to the head and neck. There is an inability to extract teeth that have been in the mean field of radiation just because of complications of osteoradionecrosis. Uncontrolled hypertension, so there are cutoffs for elective and emergency dental procedures. As well, the lidocaine with epi that's used for pain control may raise blood pressure. Artificial heart valves, or when a person is at increased risk for endocarditis, giving antibiotics prior to cleanings and tooth extractions. Prosthetic joints, so antibiotics in that immediate post-operative period. Arrhythmias, so caution is advised when using electrocautery or ultrasonic devices for patients that have pacemakers and ICDs. Okay, So I really hope that I've been able to stress how effective two-way communication between medicine and dental professionals is critical, especially for patients who are medically complex, and of course for those that take anticoagulants or require antibiotic prophylaxis. The last point I want to briefly mention is neglect and abuse, and that the first presentation may be oral. So of course, we'll look for signs of malnutrition and dehydration and poor hygiene, but especially poor oral hygiene. And then looking for things like broken teeth or dentures and unexplained or implausible trauma to the mouth and the oral cavity can also be signs of abuse. So some take-home messages that I hope stick with you all. We know the geriatric population is growing, and so of course they have increasing oral needs. Quality of life and chronic disease management, it can be improved with attention to oral health. We really should be encouraging routine dental visits for comprehensive oral assessments with all geriatric patients. And medications with negative oral consequences should be monitored and minimized if at all possible. All right, thank you so much for listening, everyone. I'm not sure how that ended up being only about half an hour, but thank you so much for listening.
Thanks, Leenah. That was really great. If anyone, first of all, please be sure you fill out the survey. I learned a bunch from your talk, so hopefully everyone can fill out their survey to share how much they also learned. Are there any questions or additional thoughts that people wanted to share? Feel free to unmute or to type them in the chat if you're not able to unmute.
Oh, I had a question, maybe either if you know, or if you know, Leenah or Dr. Jeffrey. So sometimes I don't always know ahead of time if there's going to be a plan for my patient to get implants as I'm treating them for osteoporosis. So I might have initiated treatment with an IV bisphosphonate, but then a few years down the line, then they need implants. So I guess I'm wondering, have I committed them forever and ever to no implants, or is there a bit of a lag time that we have that I could recommend? I'm seeing you shake your head, Dr. Jeffrey.
Well, usually the bisphosphonates, it stays in the body. So even if you have diabetic patients, that might not also be candidates for implants. So I think the better thing is to work with the dentist that is providing care to your patient and plan that before you start the bisphosphonate treatment, so that you could have possible like extractions done before you start the IV or the oral bisphosphonates, or you can have root canal treatments instead of extractions. So there are alternatives. And since I work with geriatric patients, I try to keep the teeth as long as possible and maybe not reach for the implant solution that early, just because of these situations. I don't know if that helped you.
Yeah, that's really helpful to think about what the alternatives are as well. Thank you.
Yes, because many dentists now might just shoot for the implant solution like right away.
There are a couple questions in the chat. First one from Dr. Banks is, can you expand on the meds that alter taste?
So what do you want to do that, Leenah? Or I usually just see that with chlorhexidine rinses, but we usually have them short term because they can also alter the the microbiome in the mouth. So you don't want them to have or to rinse with bisphosphonate over a number of years, maybe just intermittent.
So,
Okay.
in,
Oh, go
sorry.
ahead, Leenah.
So when I was researching for this talk, what I found, yes, like Dr. Jeffrey said, chlorhexidine, but also antibiotics and antifungals, commonly altering taste, as well as a big culprit I saw was anticonvulsants.
And also when you have a dry mouth or xerostomia, that can also lead to, of course, like to taste alterations.
Lots of meds.
And we have no control over that. So I'm so happy about your talk. It was so comprehensive. Thank you.
Really was, Leenah. There's another question about, are there low-cost dental clinics where patient can get care? And I guess the broader question is, how do we find that information, for our area?
Yeah. So I run a geriatric clinic out in Linwood that is actually free for the patients. It's low income, so they need to disclose their income and apply to be part of the clinic. And that is up in Linwood. The dental schools throughout the country, because depending on where you are, they always take Apple Health or like the state insurance, and that's about the least expensive treatment that you can get, and it's really good quality care. State insurance doesn't reimburse crowns, implants, and the more quality type of denture that you would like to give a patient, or now I'm meaning the partial dentures. So some might need to pay out of pocket, but also the normal fees are lower at the dental school. You just pay with your time instead, but the quality is high. But no one knows about this clinic, right? Because we run it like 1 day a week. So, and I have, I think, a waiting list of 30, 40 patients right now.
How do we get information about finding this clinic, your clinic?
You contact me. No, yeah. So contact the School of Dentistry. But you can email me too, and I can forward it. There are many of the community health clinics might not do crowns, and they might not do dentures. And that's what most elderly patients need. And the elderly patients also take a longer time when they are in the chair, just to get into the chair, and regular bathroom visits like throughout the appointment. So I would recommend your patient here in this area to actually seek care at the dental school.
Dr. Grunwald also mentioned that neighbor care health is also another option, and other community health clinics. And while we're getting to the next question, I know we have at least one person from the Area Agency on Aging on, and I don't know if they have any way that they help connect older adults to community-based resources for oral health, or if there are other things available through the county that they wanted to share.
So you can always contact your senior center, your local senior center, because they are the ones that have usually a list of resources. So I had a dental clinic inside of a senior center out in Linwood previously, before we moved to Lehigh.
I don't know if Mary Pat's able to unmute. Mary Pat, do you know any more about connecting to community resources?
They can call Community Living Connections. That's a resource. And also, many of the federally qualified health centers may have access. I think the thing that we found during COVID, and thank you, Dr. Jeffrey, excellent, She collaborated on an oral health article with me. Wonderful. You're amazing. Is that we lost some of our dentists. So we really need to continue to support dentistry, oral health. And I think sometimes our older adults think that since I went to the dentist, that's my oral health. So there's a lot of education around what you can do outside of the dentist's office to really help your oral health and hygiene. Thank you.
I
Thanks,
think
Mary.
sorry, I think what you should do, encourage everyone to get state insurance, because the hygiene visits and the dental like checkups are the most important ones.
There's a question from Dr. Harper. Welcome, Dr. Harper. There are, you know, a variety of antidepressants that can cause xerostomia, and she's wondering if you recommend saliva substitutes for patients if that's a problem and they need to continue those medications.
So I think from what I had been reading, that the xerostomia is more likely to occur the more medications are on that will result in xerostomia. So I'm not sure if just one antidepressant or one medication that has effect on saliva secretion that will necessitate a saliva substitute. But I think certainly if a patient is on multiple or is, you know, complaining, coming in with symptoms, then certainly I think a saliva substitute is a good idea.
The next question is, and thank you for answering all these questions. Do you recommend or water picks, or are those ever supplied to folks with chronic poor oral hygiene?
I think it depends on the patient's dexterity, if they're able to hold the water pick, if it's too heavy. But it is, and you have water everywhere, but it is a super good tool. So if you can use it, go for it.
Great. Lots of questions. It's so great to hear your presentation, Leenah, and I appreciate Dr. Jeffrey, you adding your expertise and encouraging our fellows to be enthusiastic about oral health and to take that away from their fellowships. It's really important. Any last questions before we wrap up today?
Oh, I just want to say one more thing. I think the Seattle King County Dental Society has a list of reduced cost clinics as well, where it breaks it down by area. So like downtown Seattle area, Northeast King County, as another resource for those of you who asked.
I'm sorry, could you repeat that about the King County?
Yes, it's the Seattle King County Dental Society website has a list of reduced cost clinics, where the list is broken down geographically. So just another resource for looking for reduced cost clinics.
I will put that link in the chat for everybody. Great. All right. Well, I love an interdisciplinary discussion. This is great. We need to work together more. I learned a bunch. Thank you for leading this, Leenah. Really appreciate it. Such a clear talk that was really comprehensive. And thank you again, Dr. Jeffrey, for adding your expertise and all of your education. And thanks everyone for engaging in a discussion. This was really great. I hope you all have a wonderful weekend, and I'll see you next time.